A big hand to all the organizers of this event. We had a wonderful evening yesterday. So the first topic is today I'm going to talk about is how to read a randomized control trial paper and how to critically appraise that. So there's this perceived misconception among doctors, among us as practicing clinicians that, I'll just do a brief.
Yeah.
So we all think that when it comes to research, it's all about statistical jugglery. The honest answer is that's just a misconception. It's not our job to do complex statistics. We're not trained to do that. It's like when you buy a computer, you don't expect to tell the software engineers what kind of programs you want on that. You don't tell him how to do his job. Rather, we tell him is that I want this computer so I can do presentations, I want to do online banking, and these are what I expect to do with this machine. Same way, when you buy a car, you don't tell them, this is the kind of design for the car I want. You tell the purpose of car is that I want to take my kids to school, I want fuel efficiency, I want safety. It's the same way with clinical trials also. You go and, this is shut down. So you have to actually tell what is your clinical question you're asking and ask them to, that's fine, it's fine. So I'm a practicing clinician, I'm not a researcher or a statistician, and I'm sure majority of you guys would identify with that kind of my role in dealing with this kind of a topic of reading a clinical trial. I also got a bit of personal bias. There's been a trend because now publications are directly linked to your CV. The quality of papers has definitely gone down. We generate more paper, which is often not even worth on it, which is printed on, and it gets published. So we got this massive junk. Their scientific validity is close to zero. I don't have any financial disclosures to make about this talk. Obviously, I do get support from my employer for ongoing professional development. So when we talk about clinical trials, there are two basic assumptions. First is the hypothesis you make should be biologically plausible. And that's a very important thing. You don't do things just because you fancy to do. If something is not biologically plausible, it's not worthy of doing a trial. It is unethical. You're wasting resources because all trials are resource intensive. Even if you have PGs doing, they're wasting their time. Effectively, they are contributing their time to do something which has no bearing in changing clinical practice, no bearing on changing patient outcomes. The next thing is that there has to be a clinical equipoise. You have to believe that the trial, especially if you're doing a randomized control trial, there has to be a clinical equipoise. What it actually implies is the participants in the trial believe that we're not sure whether this intervention works or it doesn't work. If everyone in the room believes that giving spinal for elective cesarean is beneficial, you should not be doing a trial telling that we want to compare GA versus subarachnoid blocks. That's immoral. That there is no place for doing a trial there. You don't tell your PG to do a trial like that. There's nothing to discuss there. It is as simple as that. In the absence of clinical equipoise, you should not do a randomized controlled trial. And the four major steps to read a paper, a randomized controlled trial paper, is that first thing is you have to know a little bit of the background. This background information can be collected from your routine clinical practice. In science, you always acquire knowledge from your colleagues, your seniors, even from your juniors, and other specialties. So you have some degree of background information, and then you improve on your information based on the hospital policies. You may read international guidelines from societies. Then you may even use stratified evidence. If it's a rare case, even a published case report is a reasonable guide to what you have to do for that. Then you go into more collated data and publish randomized controlled trials. And then you also have to figure out why the trial is done. What was the reason for the clinical equipoise? The next step is to have a close look at the internal validity of the trial. In simple English, what it means is that was the trial done properly? Okay? We'll go through the multiple steps at looking at the internal validity of trial in the subsequent slides, but it's one of the most important things. If a trial is not internally valid, it has no effect. It's basically garbage. It's not, whereas external validity refers to whether the trial applies to my population. Okay? If a trial has no internal validity or internal validity is questionable, it is not applied anywhere. It is not even worth the paper it's printed on. And then at the end of the day, you need to make your own conclusion. It's not what the author writes in his conclusions. So if you are someone who fancies practice change based on conclusions of a single trial or even a meta-analysis, and you don't do your basic homework, then you're basically concluding the wrong things. So in effect, reading conclusions and making conclusions out of it is the wrong scientific approach. Now, back to internal validity, what it actually means is the accuracy of the trial and whether the trial design was done appropriately and was the trial conducted in the way it's expected to be. And a trial, like I mentioned previously, this is a very important point. A trial lacking internal validity should not be applied to any clinical setting. So when we look at the internal validity, the first question is the research design. Did the researchers ask the right questions? Did they look into the two basic assumptions? Was it biologically plausible, and was there an actual clinical equipoise? The next thing is sample size. You do a power analysis, leave it to the statisticians. If you don't understand how to do the power analysis, you're not going to be criticized for not knowing it. It's not your core business. And some of the trials which would need larger sample sizes are when the treatment effect is small, or when there is you're doing with a heterogeneous population, so there's a large variation of data, or when you got small type 1 error. Type 1 error means by chance, you may find a relationship or some kind of association. And type 2 is when there is actually a association, but because you didn't detect, you would say there is no association. So that's a type 2. So if a trial has larger power, or the difference 1 minus type 2 error, they also would need a larger sample population. Then the next part, after looking to the trial design, is looking at how the trial was done. That's the second part of the internal validity, the conduct of the trial, whether the researchers did enough to minimize the risk of bias, both systematic as well as the random error. These days, any trial which is done well will have a CONSORT approach. What it means is that they will have in the first section of the results a kind of format like that. So they will have told how many patients were assessed for eligibility, subsequently enrolled, how was the randomization done, how was the blinding done, allocation, follow-up, all those things have to come in a similar tabulated form. If it's not there, you would see in papers written before 2010, this is probably not the case, but any meaningful paper after 2010 will have this. If you don't have this, your credibility of the trial is very low, and no one is going to be quoting your paper in any way. And this has become very important these days, because any trial is eventually going to be looked at what is its impact on other practitioners. So they say that if a paper is quoted multiple times, and it even boils down to the journals, they call it the impact factor. So it's like how many times. It's not like how many subscribers the journal has. It's like how many times a published paper is quoted. And that's what translates into the impact factor. Then bigger trials should always have things like interim analysis, so that sometimes you would have thought you would have to take 2,000 patients, but by the time you have enrolled only 1,000 patients, you would have an idea that there is a benefit or there is a harm. Or sometimes that even if you do this trial to 2,000 patients, you may not do any difference. If it's 500 by 499 split and one patient missing, even if you extend it to 2,000 or 3,000, there wouldn't be a reason to find a different kind of outcome. So those trials will be stopped. Then I know that this all sounds too much for most clinicians. We have time limitations, we have understanding limitations too. So I personally use a kind of cheat sheet. So I call them like a surrogate for the non-researchers. Usually trials which are published with a CONSORT approach in major peer-reviewed journals and which have a reasonable impact factor, they are more reliable. It's not because it's coming from English-speaking countries or more advanced health systems. It is just because they've got greater scrutiny, they've got more resources allocated for that, so it's not like a hot-potch job. So as more scrutiny is there, obviously things are done a bit better. And the trial protocol of major trials or important trials will always be available on the web. You can see the trial protocol of the APPRAISAL trial or all major trials. They would be even published before the trial starts enrolling. So it's open for comments, and even if you're not a part of the research team, you can obviously comment on it. And if it's appropriate, they would have an option of making changes, and it can be even brought up after publications for looking into whether there was bias and things like that. Then another easy way of finding out if usually the trials done by clinical trial groups, wherever they come from, are more reliable, simply because there are more heads involved, they're more supported, they're more resourced. The next section is about external validity of a trial, and this is very important because especially in the developing world, we don't have our own data to change our practice or guide our practice. So when you read a paper, you must always see whether this is really applicable to my population, you know. We know that a lot of people work in neurointensive care, they don't have ICP monitors, and they want to make practice changes based on trials done in different health systems, and sometimes it sounds crazy. If I ask you guys, like, we don't have BP monitors or BP apparatus in this room, I think hypertension is something of a serious illness, everyone would benefit, and you say that because we don't have BP apparatus, now everyone go on, you know, metoprolol and maybe amlodipine at night. How many of you would agree to that? They'll think that, yeah, this guy is really crazy. But that's what happens in our neurointensive care. We say, oh, too hard to monitor in ICP monitoring, that's fine. Then you should not be using ICP-directed approaches because you don't know what you're even trying to treat. So those are like fundamental fallacies, and we think that, oh, well, you know, it's Brain Trauma Foundation guidelines. So it is the external validity of even some major guidelines are close to zero in our setup, and we must be very much cognizant of that. And there is also environmental validity, like, you know, when you're doing things like complex interventions like ECMOs, it's a newer trend in intensive care, even in here. So we must accept the fact that our mortality is going to be high if we are on a learning process. So when we even counsel our patients, you know, it's going to cost you 1 lakh rupees a day. The outcomes are better, but the outcomes are better in units which have been doing for a fair length of time with better resources. We don't know what our outcomes are going to be, so you have to be honest and upfronting, because someone can actually complain against you telling that you did your first ECMO and it cost me so much money and my father died horribly because you lied to me. So that's where it stands. So even in consenting process, when you quote someone else's trials, you must be very careful. And even things like, there is a difference of application of scientific evidence from one section of population in the same country, in the same health system, like daily interruption of sedation. People keep talking about it all the time now, telling that it will get my patient out of intensive care quick. It's bullshit when you apply it to neurosurgical ICU. The whole reason you sedated them is that you want to give them effectively a brain rest. And what are you doing every day is turn everything off, and you go away for tea and telling, oh, well, is he waking up? So you're effectively creating a daily intracranial hypertensive crisis because you don't understand what you're doing, or you didn't understand the paper you read. Now, with this in mind, I'm trying to attempt to see whether we can critically appraise a paper which created a lot of debate in the last 10 years, or rather 15 years, after Rivers from the US published a trial called the early goal-directed therapy. When it's offered in the emergency department for 6 hours, it was going to provide mortality benefit even at the end of 60 days. And it is like a 10% improvement in survival. The impact of this paper was so much that it got into the first surviving sepsis guidelines, you know? And everyone thought, this is the word of God, this is the new Bible, and we have to do it. And if you look at what he did, he enrolled patients. I don't know whether anyone of you would be able to see that, but in the gist of it is that he took septic patients in septic shock, systolic blood pressure less than 90 and lactate more than 4, and then randomized them into 2 groups. Some of them got the standard care in his hospital, the rest of them got a early goal-directed therapy, which was like you put some hemodynamic parameters and central venous oxygen as a guide and treat them to achieve those goals. So the achievements of the targets was met by fluid boluses, use of vasopressors for blood pressure, inotropes if the cardiac output was low. So central venous saturation as a physiological variable is dependent on 3 things. One is you got low oxygen gas exchange happening, so you have to optimize your ventilation. That's step 1. And step 2 is you ensure there is enough cardiac output, so you titrate with inotropes. And step 3 was to transfuse blood to keep a hemoglobin about 100 grams per deciliter, or 30% hematocrit. So he was transfusing a fair few patients to achieve his SCVO2 of 30%. How the protocol was implemented was that they got either supplemental oxygen or intubation, if appropriate, and then sedated, paralyzed, and all the things we mentioned before. And in terms of outcomes, he told that patients in the standard therapy group had an in-hospital mortality close to 47%, and early goal-directed therapy had a 30.5, so 15% improvement in survival. And this continued even at 60 days, But the catch was that 60% of his patients died at 60 days, and 45% of the early goal-directed patients also died. This was kind of overlooked by a lot of other experts in the field, but it was still like the dogma. That's what you need to do when a patient comes with septic shock. Now, if you look the way how we are supposed to have read the paper and look at it, you could see there were a fair few flaws. The biological plausibility overall was fine, but liberal transfusion policy, which he did quite liberally, was being criticized from evidence emerging in a lot of other parts of intensive care. We knew that a hemoglobin was 70 was fine. If you over-transfuse, there were more transfusion-associated complications. And there was also a big trial which came out in 2008, not directly related with sepsis, but this is to do with blood sugar control. We were bitten very badly that time when we took the word of God of Vandenberg as tied blood sugar control in almost all subspecialties of medicine was going to provide an improved survival. But when we did it a multicentric trial, we found that there was actually a tendency of harm. And the interpretation in this context was that chasing a single physiological variable is not in the patient's best interest. It may make you feel a bit better, but it doesn't guarantee a good outcome. So the experts subsequently reviewed and thought, yes, we have a bit of clinical equipoise here. The whole trial will need to be done or redone again. And then there was problems with internal validity. This is pre-CONSORT era, so the way he disclosed his data was a bit dodgy. We didn't know how many patients came into his intensive care, how many of them actually had septic shock. All we know is that he took 300 patients on both arms. Whether the 300 was taken from a total of 3,000 patients who come in, so it is not even representative of his own sample population. Then there was 11% people who dropped out of the trial during the study process. Usually you expect around 5%, but if it's more than 10, and you're publishing your data as per intention to treat, which is fine, but you should also have a obligation to do data analysis per protocol and see whether the results would stay the same. If it stays the same, then it's fine, But if you're getting opposite results when you analyze intention per protocol and per protocol, then the study's credibility is going to go significantly down. And to make matters worse, he was using this continuous SCVO2, which is like monitoring the saturations in the central vein using a fiber optic saturation probe, just like the pulse ox. And that is being manufactured by Edward Life Sciences. And they were also one of the co-sponsors of the study. Makes you wonder, is there some kind of dubious relationship here? So, and then the problem of external validity, single center, high baseline mortality. The study was done in Detroit. We believe everything is fine in America. It's not the case. Detroit is one of the poor areas. It's where all the big car manufacturers were. The study is done in 1996 to 2000. Looking closely, that's where Ford, General Motors, Chrysler, everyone lives. And they're laid out like thousands of workers. So obviously they're going to die because they're so poor. They're not even representative of the average US population. Forget about India. So the external validity was probably close to zero, maybe in another Detroit hospital. That's where it boils down to. And then there was also issues with most units, even in the developed world. It is not standard of care to have something like a SCVO2 to monitor. So if you're asking every unit to buy because you want the early goal-directed therapy, it's going to be a huge expense. And then initially when we implemented the protocol, we found that patients were staying longer in emergency departments because you believed that was the case, or that was what was to be done. So again, this will sound a bit challenging because so much information to integrate. If you're a clinician who doesn't have time, the easiest way is to go and read editorials after the trial. Most reputed journals, like any major trial coming in New England Journal of Medicine, would have an editorial in the same publication. So that will give a different opinion, not just the authors or the study group's view on it. And it'll at least point towards either ongoing clinical equipoise, what their problem with their external or internal validity and things like that. And the worst thing is you change your practice based on a single trial. It is dangerous. It's like a little knowledge is a dangerous thing. So because of the clinical equipoise, we decided to do a trial, not one, not two, we actually did 3. And we did it in 3 separate continents, comparable health systems, and this is what we found. There was no mortality benefit with early goal-directed therapy. And then you can see that each trial had different the American trial of process had mortalities in the range of 30s, whereas the British was also pretty close, whereas in Australia, probably we have a different admission criteria and things, and a different subgroups of populations. It is like 18. So the results overall says that even in the sickest or in the less sick ones too, it's not beneficial. And these days, no trial stops or gives the final verdict. So then it's the days of meta-analysis. If you're kind of a skeptic, you would say you torture data enough, you will submit to anything. So you may take meta-analysis also with a pinch of salt. So intensive care medicine published this meta-analysis. I don't think most of you would be able to see the forest plot, but you have to probably trust what I say now, that the forest plot is that if there are multiple trials done looking for a similar outcome in the same groups of patients, you will see what was the final outcomes and club them all together, and you plot into this what you call as a forest plot, and you see a rhombus. So if the rhombus is towards the benefit, the intervention side as a benefit without crossing the midline at all, then you would say the meta-analysis suggests there was a benefit. If it's crossing the midline, then you would say it's not beneficial, or if it's in the completely towards the control group, you would say it causes harm. So the way the researchers of intensive care medicine, which is the mouthpiece journal of European Society of Intensive Care Medicine, did was they told no point in continuing with early goal-directed therapy. So you would say, well, now the case rests here. You know, we've done enough trials. Society of the European Society of Intensive Care Medicine says, now it's not useful. Just wait. This is what comes in the next edition of Indian Journal of Critical Care Medicine. Same topic, early goal-directed therapy reduces mortality in adult patients with severe sepsis and septic shock. They do a systematic review and a meta-analysis. This is actually published after the Intensive Care Medicine Journal's publication came. Well, I know people like to be skeptical about data coming from the developed world. Sometimes it has fair reasons, but what they did was that they did subgroup analysis, and they told that we should see in comparison to our health system, in low middle, so they put a lot of clauses, you know, in low middle income countries, if you're working in a single center and if your trial enrollment is less than 500, and they use pre-2008 data. So do all these things help you as a reader to say whether you will use early goal-directed therapy? No, so, you know, there's only so much all these researchers, all these people who do meta-analysis can do. At the end of the day, you are accountable to your patients and you have to come up with your own conclusions. So this is the forest plot from the Indian Journal telling that how significant benefit they got. So the way I would conclude on early goal-directed therapy is that as a bundle, it's probably not it's definitely not necessary in my practice. Some of the aspects of it is quite relevant still, like early resuscitation is critical to improve the outcomes of septic shock. Some components, when coupled with appropriate antibiotics and source control, is very relevant. You know, no one debates the role of antibiotics and source control. That is not early goal-directed therapy was trying to look for. Like the components which are beneficial are timely fluid resuscitation, timely initiation of vasopressors and inotropes if appropriate. SCVO2 is maybe used as a tool, but it's definitely not a target to be chased, especially if the patient is well, and no point in using a liberal transfusion policy in septic shock.
Sir, please conclude in 5 minutes.
Okay, so I can definitely have time for some questions too. So what's the take-home message on how to read a randomized controlled trial? First is you have to get the background information right. You know, it's hard work, but it's important. If you don't have the background information, pretty hard to make any meaningful sense out of what you're reading. Next thing is that initially it'll be very hard, but you start making an attempt to see whether the trial is internally and externally valid. With practice, you start getting better at it. External validity is much more easy. You know, you look at the mortality, is it comparable in the control group to your arms and things like that, what infrastructure they had. It'll give you kind of an idea. Never conclude by reading the conclusions. Make it a habit to read editorials along with you read the trial paper. At the end of the day, you have to draw your own conclusions. And true evidence-based medicine is about translating evidence from the books to the bedside. The rest of it is all, you know, your craze for publications, I would say. Thank you. So.
First of all, like you said, and I have to admit that I do have this habit of reading a conclusion of the study, so I admit I am one of those. So maybe after this I will change my practice. Thank you.